In this segment, we join Dr. El Said as the patient returns for an appointment 7 months after initial treatment.
Okay, today we're doing the final try-in for Nancy's prosthesis. Last time, let me remove her try-in prosthesis. It's pretty retentive. We tried in the framework and picked up all the caps using a resin cement in the framework and sent it back to the lab, which waxed in all the teeth. And I've done some modifications since I've received it back. I've decided to remove the second molar to reduce or improve the anteroposterior spread and the cantilever. And we're gonna shorten the whole distal extension area. I've also waxed in singuli for the teeth to improve the occlusal contacts, give her centric contacts on the anterior since she's a little bit class 2-ish. And here it goes. It just has to be lined up and it snaps right in. It's very retentive. She has 6 4-degree taper syncones. On the lower, she has her bisque bake PFM. And I've added some wax to where we need to add more porcelain. Right now we're really perfecting everything. We're trying to get the occlusion and the aesthetics to be right on. And go ahead and bite for me, Nancy. And relax your jaw open and relax and bite again. And the bite is on. So all we need to do now is just approve aesthetics, check midline, plane, everything that needs to be adjusted, and we'll go to a process. So next time she'll come in and we'll put the same prosthesis in, only finished and glazed on the lower and processed and polished on the upper. I've started off looking at the midline and the plane and the smile line. I'm liking.
Looks good.
It looks great. I'd need to tuck the necks in just a little bit from the profile. They look a little bit like they're canted down. And look the other way for me, Nancy. So this is where it's great to have the lab master ceramist with me, because he becomes part of the team and he can see the patient.
Number 9 looks a little bit more.
A little bit more tilted, I agree.
Yeah.
The canine here also needs to be, turn your head towards me.
Come
Like
in
a little
bit,
strong, yeah, come in a little bit.
But the midline is correct.
Good,
and
the plane
length,
is great.
yeah, occlusal
And the bite for me, Nancy, and the bite is right on. We have everything that we need.
The lowers, the posteriors, they need to come in. They're showing too much here. Open
On
a
the
little.
left side.
Cuspid and the 2 white
Okay.
cuspid.
Okay.
Need to
So-
bring them in. This side is better. Close.
Yeah, I think we've had this before. I tried to tuck him in a little bit. I
we
probably
need
should have
to
done a
bring
little
them-
bit more.
Yeah.
And then have the canine follow too. That's
Mhm.
probably why the upper canine is out. No.
Open.
And just relax your lips and have your lips touch. Kind of lick your lips and see if you can get your lips to touch without your teeth being in the way. Okay. Can you tap your teeth together with your lips to... There's room to move. Okay, good. Count from 60 to 70 for me.
60, 61, 62, 63, 64, 65, 66, 67, 68, 69, 70.
Okay, I feel like if we are going to close up the vertical a little bit, it should be off the lower, if we can. If we can,
Yeah.
just a little bit. Okay? When you look in the profile of the teeth, you will notice that the neck, especially of tooth number 9, sticks out a little bit further, making the tooth look like it's inclined backwards. Kind of the neck sticks out further than the incisal edge. And ideally, you want to have the neck a little bit behind. So we're going to do that. We're going to remove that tooth. These two, actually, 9 needs more, but both will be taken out. We'll grind a little bit off the back of the tooth and reset it in the wax with a better profile. Now, this is a kind of thing that we would not need to do another try-in. It's a very slight adjustment. On the canine, it also looked a little bit prominent on the left side compared to the right side, so we'll do that too. But another thing that Christian pointed out was in Nancy's mouth on the temporary, that the posterior teeth on the lower bridge stick out a little bit further out. So we'll tuck these in, and that will allow us to be able to push that canine back in. Again, very, very subtle changes, modifications. That was the try-in. We checked for final adjustments. We're so close that nothing will have to be done in the mouth. And I'm just going to put her temporaries back on. Her tissue health is great. I'm sure it looks awesome. Here you go. Those are the abutments, 6 in cones, 4-degree taper. And her tissue health is very good. Okay, and all we have to do now is just cement the lower temporary bridge back in. And you'll be done. I'm gonna go ahead and recap. Nancy was restored in the upper arch with syncone abutments. They're ankylose syncones, and these abutments are based on the concept of telescopic crowns. They're machined metal to metal fit, very precise. So they take the prothesis, the overdenture, from being implant retained to implant retained and supported. They have 360-degree rotational freedom, so by adjusting them, you can compensate for any misangulations in the implants. So the syncones offer optimum retention. They're very cost effective because they're single standing, and they were meant for immediate loading under optimum conditions, which would be 4 implants would be the least number recommended for the mandible, and 6 in the maxilla. And in the mandible, if no bone grafting is required, it can be immediately loaded, and we've tried to immediately load them in the maxilla without any problems as well. Nancy presented to us in March of 2005. She's a 61-year-old female, a typical dental phobic. She's what I would term a dental avoidance case. She tried to avoid the dentist by all means and at any cost. And when she came in, she had very extensive problems. So if we look at the x-ray, her treatment plan comprised of extracting all remaining upper teeth and delivering an immediate denture. On the lower, we opted for extraction of the molar, which had bifurcation involvement, and we opted to maintain or keep the bicuspids and cuspid on either side, which were in fair shape, and by splinting them in a fixed partial denture, we went back after that, after the provisionalization stage, and re-evaluated the gum health, the periodontal health, and the mobility of the teeth, and everything improved dramatically. That this treatment plan was what we carried out. In November of 2005, Nancy came in. She had her extractions done. Her lower remaining teeth, the bicuspids and cuspid on either side, were prepped. A temporary provisional bridge was put on the lower teeth, and an immediate upper denture was delivered. We allowed Nancy some healing time, and during that healing time, we started immediately with our diagnostic workup. Her upper immediate denture was duplicated, and that was used as a radiographic guide for CAT scan. Her CAT scan was moved into the Simplan software, and the surgical planning took place. 6 implants were placed, and the exact angulations of the implants to each other was measured so that I can go ahead and select all the prosthetic parts that I would need. And you can see here on the bottom the angles. Over on this side, there's 6 implants that you can see from a side view. You can see how perfectly superimposed the 2 posterior implants are right to left, and that there's an angle that the anterior implants do relative to the plane of the posterior implants. And that angle was measured, and we knew that when surgery time comes, we're going to use 15-degree angled abutments on all implants to angle the anterior implant abutments in and angle the posterior ones palatally. And this way we knew that everything will draw. The images were sent to a CAD/CAM surgical guide company, and we received back a series of surgical guides that Dr. Maurice Salama used during his surgery to place the implants in the exact position that we had planned on the Simplant software. In March of 2006, she had the surgery. She received 6 ankylose implants using the surgical guides as described, and the Syncone abutments were connected using the same angulations that we had pre-selected prior to the surgery. And we immediately loaded those 6 implants. The bone quality was great. We actually started off with 6-degree taper, which is recommended by the company. And these were found to be not retentive enough, and we attribute that to the perfect alignment. So we switched up to 4-degree taper caps, and the palatal coverage was eliminated on her immediate denture on the day of surgery. And we took an x-ray I believe a couple of weeks after, and things looked great. And Nancy healed very well. So that's her intraoral views. Tissue healing was perfect. And I started planning to make my impressions. I checked alignment. And what I did is I put the gold caps or the retentive caps in her mouth and bridged them all together with pattern resin. Then we picked this up in an impression, a border molded impression for a complete denture in case we need to extend our prothesis to the vestibule. And then it was poured in the lab using Durlay dyes, and we rendered a model that was going to be our working model that will help me make a record base with a wax rim, set teeth, determine where the teeth are going to go again, and then use that setup to make the framework, because we wanted to rigidly connect those abutments. Now the thing about the Syncones, because they are metal to metal fit, they transfer all the forces to the implants. So what that does is, the thing about not wanting to splint in the upper, not wanting to not splint in the maxilla. Well, we utilized a metal framework to get that rigidity, that rigid connection between the abutments. We used the same concept that was described in the telescopic crown concept. And after trying and determining exactly where the teeth are, the cast was indexed on the outer periphery, and a putty index was placed to indicate where the teeth were, and the metal framework, the rigid connection between the implants, was fabricated using this as a guide, knowing where the teeth are going to have to go. The housings were reduced and etched, roughened, and the metal framework was fabricated to fit over the housings, just like that. When Nancy came in for the metal try-in, the gold or taper caps were picked up in the metal framework. They were picked up using resin cement. I used Unisem for that. And then a new impression was made using another custom tray, picking up the whole assembly of taper caps and metal framework. And a new model was poured. Onto that new model, the teeth were reset, reoriented, and reset into the metal framework. And a few things that I will have to point out in this slide is, if you notice the most anterior, most posterior implants, you will see that we have an adequate anteroposterior spread. However, in the maxilla, you still don't want to cantilever that far back. So even though the lab set the 2 molars in, I will probably remove the second molar and go to this area, kind of reduce the prothesis to this extension and no further back. On the lower, we had our fixed partial denture fabricated, and we're working the occlusion and everything together. I would want to deliver both protheses on the same day. These are the front and side views of the case coming back from the lab on the articulator. Some modifications were done. We had to tighten the occlusion right here, and we added a lingual ledge here to build up the cinguli of the front teeth to tighten the occlusion incentric between the lower anteriors and the upper anteriors. We thereafter moved into the try-in phase. If everything went well on the try-in, the only thing left to be done would be the completion, processing of the upper in acrylic and custom staining and custom characterizing, and characterizing the lower and adjusting final adjustments and glazing. And Nancy should be ready next time she comes in for delivery of her prosthesis. Her treatment would be complete. After surgery, the patient is usually instructed to keep the denture in for 1 week and use antimicrobial mouthwash to keep their mouth clean, and then start removing it after that, cleaning it out, keeping it in for 3 days, and then again twice for 3 days, and then every day after that. Limitation to soft diet for the first 2 weeks. That's provided that, of course, the implants are immediately loaded. And thereafter, just regular diet. And Nancy has been a great, very cooperative patient, healed great, did everything right. Her case went uneventful.